This video, I will present our technique of isoperistaltic bowel anastomosis in robotic radical cystectomy. Preliminary results are presented of this prospective cohort study using this technique, which has shown significant improvement in postoperative ileus rates. Total 10 patients of data is available to analyze. Mean age of the patient was 71 years. Mean post-op date to CRP was 166, and only one patient had CRP more than 200 on day 2. An ileus requiring nasogastric tube insertion for 48 hours. This ileus rate was 10%, which is considerably better than reported earlier rates. We begin by isolating a segment of distal ileum for ileal conduit 25 cm from IC junction. We use two stay suture 25 cm apart. Next, a mesenteric window is developed at the distal end of the segment, followed by at the proximal end at the stay suture site. We divide the distal end at the stay suture site using Sureform 60 stapler, followed by division of the mesentery at the same level with the vessel sealer. We position the ileal conduit segment posteriorly and bring the distal end of the bowel anteriorly. Now we divide the proximal part of the bowel using Sureform 60 stapler, followed by division of the mesentery with the vessel seal. Following this, we reposition the bowel segment, bringing the distal segment posteriorly and proximal segment anteriorly for the ICG study. The ileal conduit segment lies posteriorly at this time. We inject ICG at a dose of 0.2 to 0.5 mg per kg intravenously, and using firefly technique, we observe the perfusion of the bowel segment, and in this case the bowel segment seems to be well perfused all the way to the stapler line at divided ends. We also check the perfusion of ileal conduit, and the proximal end of this ileal conduit in this case look slightly less perfused, which we left for monitoring to be observed intraoperatively. The distal end of the ileal conduit seems fine. After this, we prepare for the bowel anastomosis. We take 8 cm of the overlap of distal and proximal bowel segment, and we make enterotomy in the proximal end at 8 cm from the divided end, followed by an enterotomy in the distal end around 2 cm away from the divided end. We leave 2 cm of the segment away from the stapler line to minimize the ischemia. Now we pass a single Sureform 60 stapler for side-to-side anastomosis, making sure that the 2 cm of the bowel is spared from the stapler line in the proximal segment of the bowel to minimize the ischemia. Once the anastomosis is completed, you can see that a 2 cm of bowel segment is free from the stapler line at both the proximal and the distal divided end. A repeat firefly shows well perfused bowel segment and also good perfusion in the proximal end of the ileal conduit. Now we prepare to close the enterotomy. It is important to start the closure of enterotomy with the posterior angle, taking a good seromuscular bite using Stratafix 30 suture, followed by closure of the entire enterotomy, taking careful seromuscular bite each time. Also, it is important to make sure that the anterior angle is closed very well. And once this is done, we do tie the Stratafix at the end, and after this we inspect the anastomoses to see how the suture line looks and that the angles have been closed nicely. Once this is done, we proceed with the next step of the cystectomy, that is with ureteroileal anastomosis. Thank you.